This program is brought to you by Emory University.
Great. So Tracy Wang's our speaker today. Tracy says I first met her when we were at a meeting in India. And it was one of those events, some of you have done these things, you go and you give the same talk 3 or 4 times, and you give 3 or 4 talks, and you sort of say, hey, with one more day, I could give the other person's talk, you know? But she's a really dynamic speaker, and it's fun to hear her talk. And she has interests that go all the way from acute care to population science to registries. It's the gamut of cardiovascular science. And she's from Duke. Doesn't say here on the slide. Oh, yes, it does. There we go. And she's been at Duke now for more than a decade. She went to Yale as an undergraduate and did almost all of her medical training at Harvard before becoming a fellow at Duke. And she hadn't left Duke at all. So it sounds like since then. So Tracy, come on up.
Thank you very much for that kind introduction, Peter. It's very nice to see some new faces and some familiar faces. I'll start out with a funny story. I used to be a rather nervous speaker, but I went to this conference. It's a small conference called TCT one year, and I was presenting one of those mini late breakers there. And for those of you who've gone to these conferences, they've now gotten quite massive. This is sitting in front of a room with about and I think around close to 10,000 people speaking, and they have these huge flashlights in front of you. And you go up there and you have 10 minutes to give your work that you've done for the last 3 or 4 years. So I'm already a nervous speaker. I'm up there in front of that. I'm very nervous. I know I have my 10 minutes. I got to get going. So I start, and I'm doing really, really well. And then about 30 seconds into this talk, there's someone tugging on the backside of my pants as I'm up there. I was kind of like, what's going on here? Never mind, I only have 10 minutes. I'm gonna keep going. No change, I'm gonna keep going, and I'm just keeping going. I get more insistent tugging on my pants, and I said, what's going on here? And so I flicked over to look at my moderator, who happens to be Spencer King, and he's laughing his head off. Right there on the moderator panel, I said, why is he laughing? And there's this insistent tug on my pants, and so I finally said, if he's laughing, I gotta look down, because I'm about to kick this person. And I look down, and it's this poor AV person who's trying to get my attention to get on a stepping stool so I could be tall enough to be above the above the podium so that the rest of the crowd can see me. So that was interesting. So I did actually take a break. I told the audience that I'm too short to give this presentation, got back on the stepping stool, and things went really well. So thank you, Dr. King, for cluing me in. So I was asked to give a talk about anything. So this is the topic that I picked. And it's a little bit of a whirlwind tour of some of the things that I've done over the last several years, which I hope will be interesting to you. I do have some grant disclosures here to show folks. I was asked to write 3 objectives, and so I kept these objectives pretty broad, but please feel free to stop me if you would like to ask any questions. But I'll start out with thinking about acute MI care, and I would say that our in-hospital performance of acute MI care has actually gotten really, really good. As you can see here, just looking at medications used as discharge for STEMI and non-STEMI patients, this is data from the NCDR registry from 2008 to 2017. You can see that we're almost above 90, and in some cases well above 95% for many of these in-hospital measures. But there's still some variability in care, and this was one of them that I picked up on a couple years ago that I thought was really, really interesting, and fortunately found it a fantastic fellow to sort of take this all the way through. But just looking at ICU utilization across U.S. hospitals, so again, this is looking at that NCDR data set, and you can see that these are among non-STEMI patients. What proportion of these patients are hospitalized in the ICU? And you can see that there is quite a large range over there. You could divide those into low, intermediate, and high. And in case you're wondering where Duke is right up there. you know, when I was a fellow there, basically all we did was go down to the ER. We got consulted on everything with a positive troponin. So leg pain and a positive troponin has to go to the ICU. So we had this rule that, and I think Abhi remembers that as well. We had this rule that all MIs, all positive troponins need to come to the ICU. So we were sort of up there in the 95 to 100% type of range. But if you look at the distribution of those ICU hospitals, how often those hospitals utilize their ICU. So here, the clustering at the bottom is hospitals that use it infrequently, meaning less than 30% of their non-STEMIs get into the hospital, versus the hospitals that use it very, very frequently. On the right-hand side, these are hospitals that admit more than 70% of their non-STEMIs to the ICU. And you just look at how high risk these patients are, you really don't see a whole lot of difference here. I mean, it's not that higher risk patients are generally being triaged. It's just really a matter of hospital care protocols. And if you look at mortality, for example, just look at the first set of three bars on the left. Hospitals that use very little ICU versus intermediate versus very high ICU, it's not really the hospitals that are putting more patients in their ICUs are actually taking better care of their patients. The mortality is really not that different here. And in fact, if you divide the patients into sort of the low risk, medium risk, and very high risk patients, and then you look again within these three bars over here, even for very, very high risk patients, ICU utilization doesn't really seem to make that big of a difference here as well. So knowing that there's this variability here, what we set out to do was to develop a risk score to say, if we were in the emergency room seeing this patient, how do we think about triaging this patient to a regular ward versus an ICU? So we developed this nice little ICU risk score from the NCDR. And this is how the risk score maps out. If you score, the risk score is on the bottom, and then the proportion of these patients that require ICU level of care. So these are patients who are intubated, who are in shock, who require pressors, who require PA catheters, if those are needed, who require other sorts of hemodynamic support. You can see that this risk score very, very nicely predicts the likelihood the patient's going to need with the highest risk score of greater than 14, meaning that the patient has about a 40% chance of requiring something that requires an ICU setting to deliver that care. And every hospital can pick whatever threshold they want. So if you are a hospital that had a lot more ICU beds, you could potentially pick a lower threshold. If you're a hospital that had very, very few ICU beds, you could potentially pick a higher threshold. Or you could think about it from the floor perspective. If your floor can handle things like non-rebreather masks, for example, without requiring someone to be sent to the ICU for closer nursing monitoring, then potentially you can pick a threshold that suits that particular hospital. What we did at Duke was we picked the threshold here where we said anything above 5 would go to the CICU, and anything below 5 can probably stay on the wards. And we decided to implement it. And we implemented in the ED, and this was primarily done by our fellows, for our fellows, so they wouldn't have to go back down to the ED every few minutes to go consult on these patients. And so we implemented EPIC a few years ago, and so this is actually something that we put into the EPIC chart. It sits on a side screen so that providers in the ED can look at whatever they're looking at and still look at this risk score. Some of this is coming directly from the records, so you can see that 5 of these fields are auto-populated. But many of these fields, unfortunately, still can't be auto-populated. So the things down here that require input, whether or not the patient's got heart failure, whether or not they're seeing ST depressions, whether or not they've had prior revas, we're working on how we can hard code some of these in. But it still required a little bit of input from the physician in order to generate a number. And then at the end of that, it gives you a risk score. It spits out the score, and it gives you a sense for how to interpret the score. And for patients who had a lower risk score from 0 to 5, we can, it makes a recommendation. This is probably not someone you need to call the CICU fellow about. This is someone that you could probably think about just triaging to the floor if you think that this person needs to be admitted. So it really empowers the ED physicians. And it made lives for our fellows much easier. And we started looking at how this could be implemented. This is very, very preliminary data. But on the top right, you can start seeing that as with any sort of alerts that you put in the medical record, it's not always 100% utilized. We know that. And so we see a lot of clinicians actually hide it. Sometimes it's popping up for reasons that are probably not worth using the risk score. But fortunately, there's only a very, very small percentage of patients for whom no score can be generated for whatever reason. We looked at utilization of the ICU for non-STEMI patients on the left, and we're still collecting some more data here to be able to look. So these are just sort of the early cuts of data from earlier this year. But we went from about a 90% range down to about a 60% range, which is pretty interesting. And then if you look at the risk of the patients that are going to the ICU versus the floor, we're now seeing a much clearer stratification of higher risk patients going to the ICU and lower risk patients being triaged to the floor. So sort of a nice example, I think, this is one that I give to our fellows quite a bit, of taking something, data from a very national level and trying to implement this on a very local level to hopefully the benefit of all. And our next step, including the CCU fellow who can get a little bit more sleep, our next step will be thinking about STEMI patients, because if you look at STEMI patients across the nation, we've got an average of about 88% of these patients being admitted to the ICU. This is 82% of patients being admitted to the ICU. So this is some early work that Jay Shavadia, one of our fellows, our former fellows, did, just looking at it stratified by first medical contact to balloon time, and looking and showing that, regardless of how early or how delayed reperfusion is here, the use of ICUs are pretty consistent. We don't seem to use that as a reason to decide whether or not to take someone into the ICU. But certainly the longer the reperfusion delay, then the higher the likelihood of requiring ICU level of care. And so on the y-axis are basically the same conditions I talked about that mandate ICU complications of care. And I think this kind of research is really helpful. So for example, I was rounding in the ICU last week. We have a 17-bed ICU. It was completely full of patients who were either on a ventilator or on a balloon pump. And a STEMI came in, and they very, very nicely reperfused the STEMI. The patient's pain-free, and the STs have resolved by the end of the case. And the interventionalist would not let the patient go to the floor. No, Tracy, this patient is a STEMI. This patient needs to be in an ICU. You need to make an ICU bed for me. Otherwise, this cath lab is just going to shut down until we can get this patient out of our cath lab into your ICU. And I said, no, I don't think you need to do that. And showed him some of the preliminary data that we're developing here. And long story short, I lost. This patient still needed to come to the ICU. I think I need to get it published first before I can convince someone. So I mentioned, you've seen this slide already, in-hospital performance seems to be doing pretty well. Abi Goyal and I did some of this work before, looking at what happens to patients after they leave the hospital, especially looking at evidence-based medication use early at 90 days and even later out to 1 year. And we can see that, we're dropping a little bit, actually quite a bit, from the 90% range that we're talking about before, to even about 60 to 70% in 90 days. And then by 1 year, I think these are pretty good estimates, where it's sort of in the 50 to 60% range. So we certainly have, and these are pretty basic medications that we think of treating all of our CAD patients. So we certainly have room to go in terms of improvement there. Hospitals may have something to do with this. So this was work done by Rob Matthews, again, another former a fellow of ours, currently one of our faculty members, and a medical student William Wong, who came from Singapore to come work with us for a couple of years. But if you think about it from a hospital standpoint, hospitals can actually exert some influence in terms of post-discharge adherence. And so you can see that if you look at this inter-hospital variation, there does seem to be some variation, especially for things like beta blockers, and maybe less variation for things like ACE inhibitors. And if you divide hospitals into those that can really get their patients to adhere to their medications versus hospitals that really have a tougher time of getting long-term adherence to their medications, and by long-term I'm saying about 90 days right now, you do see that the patients patients who are discharged from hospitals with higher adherence tend to do better than those who are discharged from hospitals with lower adherence. And so for us, this triggered a lot of QI activities in terms of trying to get our outpatient clinics to really pay attention to the use of these therapies in stable ischemic heart disease. And this is just a quick snapshot. We actually divided our clinicians into a couple of clinicians. These are the advanced practice providers. These are the interventional cardiologists in our clinics. These are some of the more sort of semi-private type of guys, and I'm part of this group here that's some of the non-interventional folks. And we all start from different levels. But as you can see, the blue is the baseline, but after we deployed that intervention, almost all of us were able to really be able to respond appropriately and sustain that level of change over time. So we know that these QI interventions do work. We also knew that we needed to get these patients after they discharged from the hospital as quickly as possible to come back in and see someone. And the question was, how quickly do we need to get people in? At that time, our QI folks pretty arbitrarily said, look, every MI patient needs an appointment within 1 week. I think we were kind of mimicking some of our heart failure folks in terms of mandating that 1 week. And so, again, this was one of our residents who did this very nice project. We were able to really look at some of the, look at just the measure like adherence, and there's 90-day adherence and 1-year adherence down below, and stratified patients based on how quick their follow-up was. This is not prospective in any way. It's all observational in a retrospective fashion, so certainly there's a little bit of a bias here in terms of how we think about these types of associations, but we really found that adherence really didn't change unless we saw the patient more than 6 weeks out from their MI. So for us, it lessened a little bit the pressures of being able to get someone into the clinic within 1 week. We certainly didn't relax all the way out to 6 weeks, but we relaxed it a little bit. We also knew that we had, being a tertiary or quaternary care center, we knew we had a problem with our transfer in patients, which makes up about a little over 40% of the patients that come in for MI. They're usually referred from an outside hospital. And we know that for the transfer in patients, a lot of times when we discharge them, we have a harder time setting follow-up for these guys because they're usually transitioning to the health system that they originated from or a provider that's much more local. Some of these come from a couple hours away from Durham, North Carolina. So on a national scale, again, this is looking at NCDR again, we see that the transferred in patients generally have a longer time to their first outpatient follow-up. And if anything, I would think of this as almost a corroboration of that early follow-up study we did before, because this time the timing of follow-up is really dictated more by geographic distance and logistic barriers than anything else. But it also makes a difference in terms of cardiovascular readmissions. I think being able to get these patients in a little bit sooner may be actually associated with preventing these cardiovascular readmissions, because in the transferred in patients, we're seeing a much higher rate of that as well. One of our issues with getting patients in to follow up is our clinicians. We have 70 plus cardiology faculty, but not all of us do clinic all the time. I personally do clinic about half a day a week. At my institution, I practice medicine about 30% of my time. And so if I discharge a patient and I want to get them in to see me within a week or within 2 weeks post-MI, it may be a little challenging if I only have a Friday morning clinic. And so at my institution, we use some non-physician providers, so these are nurse practitioners or physician assistants. And we thought it might be interesting to look at this on a national level just to kind of get a better sense for how these providers are being used on a national level. And so as you can see, based on the ends at the top, only about 10% of our post-MI patients are being seen post-discharge by NPPAs. I was a little surprised by that number just because our practice tends to use a lot of NPPAs, especially for these perhaps more routine post-MI visits. Our original hypothesis was, if we're discharging a patient, the patient's pretty straightforward, that the straightforward patients would go to the NPPAs, and the less straightforward patients would maybe be preferentially directed to a physician clinic. But if you take a closer look at this table, we're actually not seeing that at all. I think what we're seeing here is that the patients who are sicker, they're older, they have a higher BMI, they're more likely to have diabetes, they're more likely to have multiple cardiovascular events. In the hospital, they're less likely to be revascularized, they're more likely to have heart failure. So I think what we're seeing is that the general sentiment is if the patient's sicker, they probably need to be seen sooner, and if they need to be seen sooner, they're going to be plugged into whatever clinic can see them, whether or not it's a physician-run clinic versus a NPPA-run clinic. So that was sort of a very interesting sort of national insight here. So we looked at a couple of outcomes for these patients, again, in a purely observational setting here, just looking at associations. And the two main outcomes we wanted to look at was medication adherence, and the second one was readmission risk. And these are just all-cause readmissions within 6 months, not necessarily cardiovascular. Keeping in mind that these are patients that are sicker and are the ones that usually come off the medications earlier. But if you look at advanced practice providers, APPs versus physician-only visits, we're seeing actually pretty comparable rates. I didn't bother putting numbers in there, but I can tell you that the p-values there are all not statistically significant here. So really pretty equivalent levels of medication adherence. And from a readmission standpoint, again, unadjusted, probably a reflection a little bit of the types of patients that are being seen by physicians only versus those that are being seen in concert by an APP versus a physician with their first visit being an APP. But after adjustment, I think we just missed statistical significance, but good enough to be able to say, you know, probably care is not substantially different. And again, keeping in mind that these are a sicker population, I think this gives us all a little bit of reassurance that we can partner effectively to deliver post-MI care here. I'm going to spend a few minutes talking about Artemis because I have to say among all the trials that I've done, this is one that I am probably the most proud of because I think we had a lot of great reasons for doing this trial. But Artemis was conceived because we know that for patients who had an acute MI, they need to be on multiple medications. They usually need to be on dual antiplatelet therapies. There are very, very clear guidelines telling us that we should be using dual antiplatelet therapy, and even some guidelines telling us that we should preferentially choose a higher potency P2Y12 over clopidogrel for these patients because of trials like Triton and Plato. But we know within the U.S. that we don't always follow our guidelines. So on the left-hand side, again, this is NCDR data showing that, you know, within the U.S. we still preferentially use clopidogrel, which is generic at the time. Oops, timer. And we are less likely to use prasugrel or ticagrelor. And then I already showed some data before about how many of these patients are stopping their treatment within 1 year. And affordability is probably one of these. This is a very nice VA study where, you know, for clopidogrel, which at the VA was about $6 per month at that time, Mike Ho and others really showed that there's still some pretty big gaps in medication use, with some people filling the same day they left the hospital versus some that filled later or never. And the median delay there was 3 days. And if you look at the incidence of death or MI, those patients certainly did worse over time. Dr. Schrank also did some very nice work earlier on showing that prescription cost was a big driver of medication adherence. If the patient's out-of-pocket copay was pretty high, then this is something that would certainly prevent them from filling their medications on time or filling their medications at all. So our hypothesis, we really had a threefold hypothesis here. It was a randomized trial, and we were hoping that if we reduce the patient's out-of-pocket burden for any P2Y12, it didn't have to be clopidogrel, it could also be ticagrelor. But if we equalize that out-of-pocket cost, and in our case, we actually made it really simple. We made the out-of-pocket cost $0 for the next year. If they did that, we thought there would be three things that happen. One, us as clinicians, when we're discharging the patients, I don't have to sorry about that. I don't have to ask the patient anymore, can you afford it if I give you a ticagrelor? Okay, so it would change our physician practices. We would be able to follow guidelines the way we think guidelines should be interpreted. B, if we made the copay 0 for the next year, hopefully that means that the patient will actually stay on the medication for a year, which is what guidelines tell us to do. And then hopefully between the combination of these two things, we would be able to get patients, so better selection of drug, better adherence to drug, we'll be able to get patients to do better over time. So those were the three key hypotheses here. Our study design was made very simple. We didn't do a patient-level randomization. We did a hospital-level randomization. Again, trying to aim for simplicity, because on a patient level, if I randomize Pooja to this study, and then you got randomized to usual care, Pooja's going to drop out of the study. Well, actually, Pooja wouldn't, but a normal person might. So we really wanted to cluster this on the hospital side of things. So if Emory was part of this and Emory got randomized to the intervention. So Duke was part of this, and my previous trial where I did cluster randomization, Duke was not randomized to the intervention. I got a bunch of crap about that. This time we were fortunately randomized to the intervention. Thank goodness I have my job. So we were able to basically discharge our patients, and we left it up to the provider to say, you can use whatever you want. You can use clopidogrel, you can use prasugrel, you can use ticagrelor, whatever you want to use, go ahead and use it. But for all the patients enrolled at Duke who got randomized to, because Duke got randomized to this intervention, we were able to give the patient a voucher card so that every time the patient goes to fill their medications, they would be able to present that voucher card, and the pharmacist would say, okay, here's your med, you don't have to pay anything today. And we did that in that way because we didn't want to make it artificial in any other way. We're not trying to get patients to take their medications. We're not calling them and saying, hey, go pick up your medications today. We're certainly not dispensing free drug to them and say, here, we're mail ordering this every 30 days to you. We are just saying, do what you usually do. All we're doing is we're taking that copay out of the equation here. And so here's hypothesis number 1. Did we change physician practice? Intervention arm on the left, usual care arm on the right. Usual care had nothing done to them. They were just enrolled like they were being followed in a registry. And so on the left-hand side, what you see is the clopidogrel bars changed. So this is the tallest bar here. It's one of the lower bars here. So we saw about a 19% decrease in clopidogrel use. And then we also saw a corresponding increase in higher potency. So yes, clinicians were able to follow guidelines a bit more closely in terms of being able to respect that 2A recommendation that we preferentially use a higher potency P2Y12. Now the second question, that was really, really tricky because the second question was about filling the drug. And there are multiple ways you could think about how to measure filling a drug. And especially if you recruit about 11,000 patients, it kind of changes how much you can really measure this. So we're in a very diverse healthcare system here where everyone's filling drugs at different places. They've got different insurance coverage, all sorts of things. So there really wasn't a great centralized way to measure adherence. So we chose the most simple, which is we call the patient up, we ask them to line up their therapies and tell us if they're sticking to their drug. So what we ended up doing was calling this patient, say, bring your med list, read us what you're taking. And we did this every 3 months. And if they weren't on it, we asked them when they stopped it. If they were still on it, we asked them if they temporarily stopped it. And using that kind of data, we were able to map out patient-reported adherence. Now, you and I both know that in research, that doesn't always cut it because patients are almost always going to say, yeah, I'm taking my medications just fine. So we knew we needed some ways of validating that. And we were pretty fortunate. Originally, this was part AIM-2 was planned as a pharmacy sub-study where we got patients' consent. We were going to go to the pharmacies. We were going to collect records from the pharmacies. Fortunately, we didn't have to do that because we ended up developing a partner that covered about 80% of pharmacies across the U.S. And so we were actually able to link about 80% of our patients to their pharmacy records, regardless of what kind of pharmacy they use, which is kind of nice. So that's we did that for a subset of our patients. And then the more nerdy, nitpicky ones, of us basically said, well, even if someone filled it, how do we know that someone's actually taking the pill and putting it into their mouths? So we begged for a little bit more money. And actually for the red group, another small subset of these patients, we actually sent a phlebotomist to their home, rang the doorbell and said, hi, I'm here to collect blood from you today. And we're checking drug level within that patient to see if they took their medications. So, so that was kind of neat that we were able to do that. And the great news is, this is the result of aim number 2. We saw the exact same results regardless of which method we used to measure adherence. That was cold sweat for me. I mean, if we didn't get matching results, I'm not sure what we would have done. But we actually did. We saw very, very similar results. So regardless of how you measured adherence, the intervention, that copay intervention that we did manage to improve adherence. Now the question is, how much do we improve it? So if you use patient-reported, non-adherence rates are much lower in the 12% versus 16% range. So the absolute difference is pretty small. It's about 3.3%. If you used pharmacy fills, they were high, non-adherence rates were a lot higher, actually. And now we start seeing a 9% difference there. Interestingly, the drug study had rates that were probably a little closer to patient-reported, and we're still trying to figure out a lot of these data. Is pharmacy data really that bad that it's overestimating non-adherence, or is patient-report really that good and that it kind of matches the drug study? So we're still trying to pore through some of those results. It turns out that you can't just send a phlebotomist to go randomly knock on someone's door and draw blood. That's not a very efficient way to run these types of trials. And so usually we had to call patients and schedule a time for the phlebotomist to come by. So you get a voicemail on your phone that says, hey, a phlebotomist is coming by to draw blood tomorrow. What are you going to do tonight? You're going to take your medications tonight. So, so that's my sort of slightly cynical bias about the last result. However, we did not meet our third outcome. When we looked at MACE, if you look at the curves, they're almost right on top of each other. So we felt pretty stupid. We proved hypothesis 1, we proved hypothesis 2. Why is it that as a result of 1 and 2 both being met, we didn't even meet hypothesis number 3? This was a head scratcher for us. It certainly created a lot of angst. When we presented it, we had a lot of questions about it. When we submitted it to the journal, I went through 4 revisions to try to answer that question, but I think we finally got the proof yesterday, so I think we finally answered their questions appropriately. But one of the reasons I think why that didn't work is because of the way that intervention was set up. So remember I said it was a voucher card. We gave the voucher card to the patient. We told the patient, take this to the pharmacy. Well, it turns out 28% of our patients in the intervention arm got the voucher and decided never to use it. Not a single time during the 12 months. Now, I didn't understand that. And maybe it's because I'm kind of a cheap person, but like, even if it cost me $5 to fill a prescription, if I got a voucher card, I'm going to use the voucher card. But apparently, our patients are not as cheap as I am. So 28% of patients, we queried them to find out why they didn't use the voucher. Only about 20% of those cases were for things like, I lost my voucher, I couldn't figure out how to use my voucher, some sort of mechanical problem that prevented them from using the voucher. A large majority of them said, I don't need the voucher. And a lot of them was kind of like, voucher? I think this speaks to study design and how you deploy an intervention. You know, we think of this as a public health policy type of trial, so we're trying to be very, very minimalistic in how we did this. But certainly that had some effect on our power calculations here. We also think that, you know, do we really convert that many patients to ticagrelor enough to make a difference? And did we really substantially affect adherence long enough, in a big enough way to affect adherence? Is that 3.3% patient-reported increase in adherence, or that 9% increase in pharmacy fill-based adherence, was that really big enough to make a difference? But, you know, simplistically, if you just divide now the intervention arm into those that did use the voucher versus in the green versus those that didn't use the voucher in the yellow, you can see that those 2 groups of patients, really their outcomes diverged very, very widely. It is not right to do what we did which is to just compare these two lines, because otherwise we kind of screwed up our randomization if we just do a subset versus the full. But just to kind of give you, this is really just sort of off the cuff, just to give you a sense of what would happen if we did that. You'd find that there is, in fact, a significant MACE difference if you just looked at those two different groups. But that was not the intent of the study here. So I've spent some time walking you through some of the systems improvement type of things, walking through some of the provider improvement type of things to try to get us towards better evidence care. And I'm going to spend the last few minutes talking a little bit about patient engagement, because certainly we need to think about all of this in concert as we think about implementation science here. And there are many, many, many ways to engage the patients now beyond our face-to-face interactions. I think many of us are already involved in very interactive communications with this. Some of us are involved in health technology type of things that we use to engage patients. And as we head around the clock, I think we're also starting to get towards sort of the caregiver side of things as well there. One of the sort of basic non-clinic visit-oriented patient interaction is with cardiac rehab. This was some of the work, and I remember, Sismita, we did some of this work early, about 10, I think more than a decade ago. You haven't changed a bit. I've aged quite a bit, so and my memory's mostly starting to go away. But this was, again, looking at the NCDR and looking at post-MI patients, and regardless of how they were revascularized, we can see that the volume of referral is okay. So if you look at the top number, about 2/3 of our patients get referred to cardiac rehab, and that's great. This is one of the Joint Commission performance measures, so it's something that people pay attention to in the in-hospital setting. While it's not close to 90%, it's still a lot higher than what we'd expect it to be if it wasn't a performance measure. And then if you look at the volume down below in terms of the amount of referrals, that's the height of these bars. And the purple part of those bars gives you the proportion of patients that actually participate in cardiac rehab after they're referred. So that rate is somewhere in the 36% range. We can certainly do better with that. We see that many of these patients are going to rehab and starting it within 4 months, within 4 weeks of discharge. And once they get started, once they have their first taste of it, the large majority are able to stick with it. They're able to complete at least 5 sessions. And actually the median number of sessions is about 26, which is sort of where the Medicare allowance is. It doesn't matter what kind of subgroup, except perhaps the smoking subgroup. There does seem to be an association of cardiac rehab participation in the number of sessions participated with mortality. You could say, hey, maybe this is a healthy adherer effect, especially since we're seeing that the smoking subgroup does not benefit, have the same relationship. So that certainly lends credence to that concept here. But let's talk about medication adherence, something that we sometimes associate with cardiac rehab, but not always. You can see here that it doesn't matter what kind of medication the patient is prescribed. The white bar are the ones who never participate in rehab. The blue and the purple are less than 26 and more than 26 sessions. We can certainly see that the patients who do end up having more prolonged participation in cardiac rehab and are more engaged are probably the ones who are able to also take their medications better. I think rehab folks spend a lot of time with the patient. They're talking about lifestyle, they're talking about physical activity, and perhaps in a way they also get a better sense of what works for the patients and how good patients' comprehension is. This is something that I have always wanted to study but didn't have a chance to until recently, when we actually built in health literacy questions into one of the studies that had nothing to do with health literacy, just to kind of get a better sense of how good patients are in terms of their health literacy, and more importantly, to get a sense for how often hospitals are screening for health literacy when they're taking care of their patients. And so I think here are some pretty neat statistics. About 1 in 5 patients have low health literacy. And these are based on survey questions we built into the questionnaire. that relate to, you know, whether or not they understand the instructions, whether or not they have to ask someone else to help them understand the instructions, whether it's a caregiver or someone else. And then if you look at hospitals and how often they screen for health literacy, we see that almost half of hospitals never even deal with this problem at all. And so certainly something that is worthy of more investigation. One of the tech companies very, very early on came to talk to me about providing a device-based coaching mechanism for the patient, where they use either phone calls and text messages and an application on the phone to really be able to deliver some of these things here about post-MI care. So nutritional information, some of the PTSD factors after an acute MI hospitalization, creating a community with others. And the folks that are doing this are actually non-physicians. They're usually nutritionists or exercise physiologists. And the idea here was to recruit not just the patient, but also the patient caregiver as well. And there's some really interesting sort of preliminary work that we did together. This was really based off of about 20 or so patients, so they're not a huge amount of data points here. On the left-hand side is a risk score called the Patient Activation Measure risk score, the PAM score. It's really one that characterizes how engaged patients and how empowered patients are in their risk factor management. And so you can see that in a simple pre and post type of setup here, this was a very small company that wasn't really interested in doing a lot of very robust research, but at that time, this was, you know, pretty neat to just being able to characterize that pre versus post. And then I thought another part that was really, really interesting was sustainability. So, you know, within the first week, week 2, week 3, week 4, does the volume of this interest wane over time? And certainly for the patient, not really. It actually sustains out to about, we went as far as 4 weeks, but, you know, I was actually expecting like week 1, really worried, want to text, want to do a lot of stuff. Week 2, getting back into normal life. Week 3, week 4, okay, I'm done. It's time to move on to the next thing. But we're really not seeing that. For the caregivers, I think they got a lot more reassurance, and by week 4, they were heading down. The texting activity was already pretty much down. So kind of gives you a sense for some of the prioritizations for patients. We know that how we get patients to take medications, for example, or to consider therapies is really dependent on how high a risk they perceive themselves to be at. And so this is work that we did with Peter that I'm very, very grateful for. Peter always gives us really great suggestions on how we think about setting things like this up. So we ended up doing a study that was a little bit more device-based and really was trying to get around this perception of risk here. And I guess it's no surprise here, if you take something really objective, like the pooled cohort equation, and you characterize patients' risk based on something like that, and you correlate that with patient-reported perceived risk, there really is no relationship here at all. It's all over the place here. And certainly that may have a lot of impact on why, you know, different types of patients with or without ASCVD are willing to take the type of therapies. And we're still, and this was early data after the 2013 guidelines came out. This was done in 2015, where we're still seeing pretty low rates of statin use and especially high-intensity statin use. So how do we present risk? So we had this device-based application, and it was actually really cool because now we randomize just by randomizing the device. So we didn't need to study this in the same survey in 7,000 patients. After a patient was enrolled, the survey itself basically randomly selected which risk to present to the patient. So some patients got 10-year risk, some patient got presented lifetime risk, and some patient presented the heart score, which is the European death risk. And it was very, very interesting. On the left-hand side is if you presented that risk number to the patient, this is how high they perceive their risk to be. And on the right-hand side is how willing they are to take therapies based on the risk presentation that they got. And so it's really interesting if you present lifetime risk. Now we're seeing numbers that are often in the 30, 40, 50% range. Patients think that's high risk, whereas if you're doing 10 years, we're talking about ranges in the 5 to 15% risk. You know, there's a big difference in terms of their high risk. And if you present death risk, interestingly, people aren't afraid of that, and mostly probably because the numbers are in the 1 to 4% range. Their willingness to treat, this is just dichotomized as very willing or somewhat willing. Again, we see very similar parallels here. If we present lifetime risk, we are sometimes much more effective in getting patients to accept statin treatment than if we present a 10-year risk. And you can see a lot of these risk calculators have changed over time to incorporate not just the 10-year risk, but the lifetime risk. And I think a lot of that had to do with being able to understand how patients perceive risk. This was another thing that was really cool. We randomized the device to give risk in different ways. They could give it as just straight text, or they could do the smiley face, frowny face thing, or they could do it as sort of a pretty simple graphic representation of this is your risk if you took a statin. And we just looked at the different ways of being able to do that. Blue is the pictogram, the smiley face or frowny face. Gray in the middle is nothing, and the bar is on the left-hand side. And interestingly, this is very discouraging to patients. My hypothesis, I'm a glass is half full. I just see that. I don't see the red. Or you could look at sort of the proportion between the red and the green, and maybe it just sort of diminishes that risk a little bit when you do that. But this was also really sort of interesting way to think about how we can depict risk to our patient. Last few minutes. So you've noticed that I've had some discussions here, but I'm certainly not very much in the traditional RCT world. I'm probably much more on this end of the spectrum, where we're talking a little bit about real-world data. And certainly there's a very wide distribution between this, with some folks saying traditional RCTs, unless we can get our participation rate up, those may not really truly reflect practice in the US. We see that only about 3% of MI patients are participating in MI trials, so thinking about how we extrapolate data from those 3% out to the 100% full spectrum of practice is sometimes a little bit challenging. But certainly anything we can do to sort of narrow that range so that we're starting to see this end and this end closely approximating each other and looking at the same population of patients would be phenomenal here. One of the barriers is an informed consent form. This was an informed consent form for our PALM registry. Peter's seen this multiple times already. For a simple registry where it's a cross-sectional registry, we're not following the patients over time. We're just getting their permission to do a 20-minute survey and give us a tube of blood. It takes 6 pages, 7 pages, plus a signature page, 8 pages. 8 pages of text just to recruit a patient into a single cross-sectional registry. Okay. So what do? We changed it up. First of all, we made it a game. This is what I call my Candyland Screen. So we made it a game. So we broke we made this a video instead of a PDF document or a piece of paper, and we broke it up into little bits, and we made it kind of fun. We put faces in front of people. That's my study coordinator, Vincent. And we had what we call BRoll shots. I learned a lot of movie terminology as part of this, where we really put some context around it. As you can see, showed some racial and gender diversity as well as part of our research process. And we implemented this as part of that iPad delivered app. So when a patient walked into our clinic, we would hand them the iPad while they're sitting in the waiting room and just say, go ahead and get started. And it was a self-drive kind of situation. So while the person's in the waiting room just sitting there twiddling their thumbs waiting to be seen, which can sometimes take about 20 to 30 minutes, they're doing this. We had some queries about this. We wondered if our coordinators had enough tech savviness to be able to deliver this. We wondered if we had the tech savviness to deliver something like this. We also wanted to do this in an outpatient setting, and we wanted to make sure people weren't resistant to that. So the blue line was our projected enrollment curve. We were planning to get 175 sites up across the U.S. They needed to be all over the U.S. in both urban and rural areas. We wanted to involve about 7,500 patients. And so the blue line is where we thought we would start, and we thought it would take this long to cross that 7,500 border. Technology being what it is, we had to deploy it 2 months later. I think iOS 8 came around at that time. That killed it for us for a couple months. And so there was a slower start, but then we saw this unbelievable enrollment curve that actually had to force us to change our plans quite a bit. For one, we couldn't get to 175 sites. By 100 sites activated, we knew we were going to run out of patients to enroll. So we ended up cutting back the number of sites we could activate in order to be fair to the later sites that came on. And we ended up crossing our enrollment line about a month and a half or 2 months before schedule. So it was about 6 weeks before schedule. So I think we are in an age where both clinics and patients are adopting the technology. In case you're wondering, the oldest person enrolled in the trial was 97 years old and did really, really fine. We thought IRBs would have a problem with this, and by the way, they did. About half of our IRBs of the 150 sites would not approve the application, which is, not inconceivable, thinking about, first of all, this being a device-based type of setup, and second of all, because we took that consent form and smashed it up and put it into a video instead. So there are a lot of hurdles to jump through. But interestingly, in the sites that did approve the video consent, it was, the startup time was actually shorter. So the sites that are really embracing this, they're not having to cross a lot of hurdles to get this up and running. So the orange bar is from when we first approached the site to when IRBs were approved the research application. So you can already see that their IRBs acted very, very quickly. And then from approval from IRB approval to activation, this is the amount of time it took to train the coordinators to be able to use the device, train our providers to say, hey, this is okay, we're going to employ this in your clinics. And then after they're fully trained and activate, the time to be able to get them to enroll the first patient in, it didn't seem like there was a big barrier. The technology was a big barrier to engaging patients. And in fact, within 7 days, the median number of 7 days, the first patient generally was improved. And there were no difference in the number of patients enrolled per week. We didn't think that this was going to be slower anyway, or because it's a new technology versus something else. And even more interesting, I think this was great in that the sites that used the video consent had more older individuals in the registry, and also more racially representative individuals in the registry as well. So to us, that's a big plus. I think part of it is, if you're old and you forgot your reading glasses at home, you come in and they shove a 8-page consent form at you. It's usually very, very intimidating. But so having that video format is helpful. And I think from the diversity standpoint, really being able to showcase diversity in research, I think is something that's a big draw for people as well. So I kind of did a little bit of a whirlwind tour of things that I've thought was really, really interesting about real-world data in acute coronary and post-MI care. And I thank you very much for listening.
Tracy, thanks so much for a great talk. We're open for questions if folks have some. I'll start out with one on the last thing with the video consent. What about the patient's perception, and it seems like they probably like that better, I bet.
Yeah, we did not formally survey that in the major trial. And Peter and I had a couple of conversations about this. We actually piloted it at Duke before we rolled out to 150 sites. And we piloted this in a post-MI population where the patient was held captive in the hospital. And we specifically piloted it in patients who were 65 and older because we wanted to get at the tech burden aspect of this. And so when we did that, we did a lot of qualitative surveys about the process, and there was a lot of trepidation about being handed a device, and for someone who's never used a device before, being able to sort of navigate some of that. But so there was a lot of that as we were going through this. There was interesting, a lot more content type of concerns that people had about it. So remember those risk scenarios that we put up there? There was a lot of sensitivity. So for example, we had one of the questions in there about perceived cancer risk. And patients were kind of like, what? There's cancer risk? There's cancer risk as part of my cholesterol lowering therapy? What's going on? And it generated a lot of angst about that. So we knew that we needed to be very, very careful about what kind of content we're putting out there, especially in an unsupervised setting where we're asking the coordinator to say, here, just take this and go have fun. I'm not going to hover over your shoulders and look at that. So that was the big piece of feedback that we got from that that qualitative piece. We had about 5 patients who'd previously been involved in a clinical trial before that had that knew what a traditional consent form looked like. And all 5 of them ranked the video consent as being a way better venue for presenting risk than their previous experience, although that was certainly very recall-based type of assessment there. And then finally, when we got to Palm and we were ready to deploy, or getting ready to deploy this to the 150 sites, we ended up doing just small focus groups just to check the content of it, just to make sure that I wasn't raising any of those red flags that came up and before. And so that was really the only assessment piece of the survey that we did before we rolled it out to the sites.
Other questions from the group?
A really nice presentation and really important work you've done related to adherence. I mean, it shows us, despite how much we dig into that, there's still this large gap. The MI-free data, tells us cost is a little piece of it, but I still think, and I want to hear your opinion certainly about, is it this gap in understanding or relationship with the healthcare system? So do you have data on either patients' self-efficacy, relationship with their clinician, or relationship with healthcare system? Because at the same time this gap still exists in adherence, we have a more and more fragmented healthcare system and delivery. And so when patients are treated in the hospital and then launched out into the big blue yonder, or those that have a consistent and prolonged relationship with a caregiver more likely to be adherent. And then it's interesting to me, we measure the people that come back to clinic. Do you have any way of looking at dashboards of people who don't come back to Duke or to their docs that you refer them to after they're discharged?
Yeah, those patients don't do well.
Yeah, they don't do well, but I think they're kind of out there. We don't, we don't ever see them back, so we don't know how they do.
So just before I answer your question, do you, so our hospital about 3 years ago decided to do a 3-day post-discharge telephone call to all patients, where they're actually reaching probably about 90% or more of their patients. I actually don't know the statistic off the top of my head, but I'm under the understanding that they actually can talk to a patient even for 5 minutes on the phone call after discharge. Is that something that you do here at all after either an MI or heart failure discharge?
Yeah, I think there's a great effort to create early touch points, post-discharge clinic.
Well, that's my question is, does that work?
It works for the people probably that come back to the visit, but it's the same thing. As you look at no-shows to the post-discharge clinic, you can almost predict who those people are. They're people that come from a distance, that don't have a strong relationship with the healthcare system or a clinician within the system. And that's why I'm asking if there's any data about either self-efficacy or, because a lot of medicine is safety and trust. And then it's communication and understanding. And these gaps, despite us giving free medicines and trying all these different initiatives, are still pretty large.
Well, I would say that there's there's data to come. I don't have data under our belts just yet. So I mentioned that our institution, we started implementing this, and we have decent touch points with the patient. It started out as being a pharmacist-led intervention at our hospital, then it became a nursing-led intervention. And quite frankly, at this point, we're wondering if it's still worth doing. These touch points are very simple. Are you understanding your meds? Do you have any questions? Reminder, you have an appointment coming up. But the reminder you have an appointment coming up is really only for patients who are following up within our system. And I showed some data about transfer-ins versus direct arrivals. I mean, even sort of a geographic barrier creates issues. And what I didn't show was some data here that looked at the transfer-ins versus arrivals. They're also not coming back to the discharging hospital if they have any issues. If they're going to seek care, they're going to seek care in an ED or something that's way outside. And so we don't, as the discharging hospital, we don't always get that feedback either that this is happening. I mean, when we're looking at our own 30-day readmission risk, we're only looking at readmission risk, quite frankly, that we know about, our own. So certainly there's a whole lot of data gaps there. With regards to the trust issue and sort of the interactions, I think a lot of that's going to come around soon. So that Artemis study that we did, we actually ended up building in some questions related to relationship with pre and post at baseline, and then over follow-up in terms of their relationship with their clinicians, and then some really nice questions about risk perception and about patient activation. So we put part of the PAM score in there as well, just to try to get a better sense of that. So I think there's more data that's going to come out to see what are the other factors that affect non-adherence. In the PALM registry, this is the one about statin use in high-risk ASCVD or non-ASCVD population. We had put in a very simple single question, or two questions. One is about their trust of their physician, and the second was about where they got their health knowledge from. And it's really, we haven't published this yet, but the physician trust one was, and part of it is sort of the way it's being asked in a survey and it being done in a clinician's office. The health trust one was not, the results were not tremendously surprising. There was sort of a high level of trust in the physician. But if you look at how patients are getting their health news, they're not actually getting it from the physician. They're getting it from many sources that are outside. And especially with statin therapy, we know that that's a barrier to us being able to prescribe appropriately dosed statin therapy or get patients on guidelines care. So I think more of that's going to come out.
I think given the time, we're going to go ahead and stop here. And anybody other questions, come on up and talk to Tracy afterwards. And again, thanks so much for a fantastic seminar.
Thanks for having me.
Really great.
The preceding program is copyrighted by Emory University.